We have another great question here. What problems or malocclusions are less predictable with Candid Pro?
Thank you for that question. We're going to start with this question, and then we're going to get to the question. We're going to answer the questions on what works really well for Candid Pro. So I don't want you all to think that we're starting negative, but I just want to share some things that are challenged not only with Candid Pro, but actually any type of aligner therapy. And then we'll go back and get to the real positive parts of aligner therapy with Candid Pro. But what these is just a simple list of less predictable malocclusions that any type of aligner therapy, no matter what company we use, it is a challenge. And then we'll share how Candid Pro, how we set things up to make it more predictable. But this first one is posterior crossbites. And these are posterior crossbites that actually involve the terminal molars. And what I mean by terminal molar is, for example, in this particular slide, it's teeth 2 and 3. So we have teeth 2 and 3 in lingual crossbite. Those are the terminal molars. You can see that tooth number 4 is in crossbite, but we can actually correct the crossbite with number 4 without a problem because we have teeth 2 and 3 to act as anchors. When we don't have a wisdom tooth or tooth number 1 present, we really do not have the anchorage sufficient enough to correct crossbites of 2 and 3. We can do it with the bicuspids, but not with the molars. When I say not with the molars, I say it's less predictable with the molars. And an example to that is you can see with this particular case, looking from the throat side out, you can see the deep intercuspation that tooth number 2 has. And in attempting to expand number 2 and 3 out of that crossbite, we have to really, we're going to be creating an anterior open bite because those lingual cusps of number 2 are going to be riding up on the lingual cusps of number 31, and that can actually create havoc and open up a big can of worms in attempting to correct this crossbite. So in order to avoid all the potential problems that we can get with this, problems like an anterior open bite or problems like significant posterior molar interferences with occlusion, we feel it's more important to leave those in position. And patients can function just fine in a crossbite position. It's the only thing is we don't have it perfect. And you know what? Sometimes we can't have everything 100% perfect, but we can make it functional. And that's why terminal molar posterior crossbites, we would rather keep them in a good functional position and maybe not go for the ideal, so we're not opening up a can of worms of problems that we have to deal with later. The next situation that's very difficult are class 3 skeletal malocclusions. And you can see from this patient and the picture of his teeth, he's in a significant underbite where he's got a very prognathic mandible and a very retrognathic maxilla. And even with brackets and wires, we can't correct this because the main problem is the bone position, is the bony disharmony. So these types of cases, we definitely recommend that is referred out to the orthodontist and the oral surgeon where surgery can be part of the treatment plan. We look at cases with really significant crowding. And, it's the term significant can be defined differently from one person to the next. So I'm just going to generally use the term significant. And this is cases, I define significant in cases where, we just cannot expand safely and that we need to gain arch length by extractions. That's the case that I think should be referred to the orthodontist, or at least if we have a Candid Pro doctor who is very well versed and has a lot of experience with aligners, we definitely can help the Candid Pro doctor work with extraction cases. Many times that's going to involve the help of elastics. So for the new doctor to come into aligner therapy, initially, I would not recommend that we do significant crowding cases right off the bat. Other challenges are definitely these ectopic erupting canines that are getting blocked out mainly because significant crowding. And you can see that there's possible gingival defects, especially with 6 and 11, and look at number 27 there. We don't want to create any further gingival defects there because of the significant crowding. So these types of situations are very difficult with aligner therapy without having tooth extractions. Other issues that are a challenge with aligners is situations where we have a patient who has a tongue thrust or a finger sucking habit or a thumb sucking habit, which we call those myofunctional problems. We know that if that myofunctional problem is not addressed prior to aligner therapy, the aligner therapy is just not going to be successful because the tongue or the finger or thumb, whatever is causing that anterior open bite, if it's still present, unfortunately, those teeth will not move, and the tongue and the thumb and the finger, they're going to always win. They're going to always win the contest. So we need to get those myofunctional problems resolved first, and then, of course, we can treat these types of open bites. One of the toughest open bites is one that goes all the way back here to the molars or the second premolar. Still can be managed, but once again, this is more than likely a myofunctional problem, or it could also be a skeletal problem where the maxilla itself is tilted. And that situation, of course, is very difficult to correct just with moving teeth. There are cases where we have lateral open bites. These are quite rare, but these are a big challenge because the myofunctional problem here is that the patient, instead of thrusting the tongue forward, they are thrusting the tongue in a width direction. I can't even make my tongue go wide, but some people can, and it can become a habit for them. And we know that the tongue is going to win out. Now, this particular slide shows that the first and second premolars have not fully erupted in the lower arch, but the upper arch they have. So we still have this lateral open bite situation where there's this big space that the tongue can occupy. Once the tongue no longer occupies that space, then very much we can go after and treat that situation. Another skeletal problem that is very difficult to treat is the class 2 skeletal problem. And you can see this particular patient has a very small mandible or retrognathic mandible. Looks like the maxilla is probably in the normal position. And as we all know, this case definitely needs to have a mandibular advancement surgery. And trying to treat this dentally, just moving teeth, it's really a disservice to the patient because we really want that patient to have the best aesthetics possible. And in order to achieve those best aesthetics, this patient does need lower jaw advancement. Getting to our last couple here. When we have a missing tooth, for example, here we can see that tooth number 30, excuse me, that's number 29, I apologize. Tooth 29 fell out or had been extracted, whatever the case might be. And as we know, over time, 30 just tips measly into that space. And it creates a periodontal problem. It creates all sorts of havoc. You can see that tooth number 4 super erupts. So it really creates a lot of problems. And of course, we try in the dental world, we try to avoid this and getting those patients treated for these problems prior to all these side effects. But many times, we don't see these patients until all of these side effects have occurred. So a challenge that we have with aligners and even with brackets and wires is to try to upright number 30 without disrupting the teeth around them. And what I mean by that is as number 30 is uprighted, it will also extrude. And as it extrudes, we're going to have a problem of the anterior bite opening. So it takes special mechanics and special tools in the orthodontist toolbox to help prevent those things. So in my opinion, these types of cases more than likely should be referred to the orthodontist. And, you can see that probably 32 should be removed to ease the situation, but I would not want to approach this with aligners. Even in my own practice, I would not want to do this because of the potential side effects that can occur. Last but not least is the attempt to intrude molars. You can see in this particular case that the posterior alveolar, super erupted because, we can see that tooth 29 and 30 and 31. I don't know what happened there, but the only way, we can restore 29, 30, and 31 is to intrude 2 and 3. Now, with aligners alone, intruding molars are very difficult. We need to gain anchorage somewhere to be able to intrude those molars. So to attempt this just with aligners, it's definitely not predictable. We can do it if we use extra anchorage like temporary anchorage screws, mini screws, and things like that, and elastomerics and springs. But for the basic Candid Pro doctor who wants to treat predictable cases, I would suggest not attempting these cases. The orthodontist and the oral surgeon have more tools in their toolbox to be able to attack these cases so that we can restore those lower posterior teeth.